Hello to all. It is my great pleasure to have a chance to present one of the challenging cases, actually the one I came across 1 month ago. A 16-year-old autistic boy came to my office with his mother for a mole check, actually for a harmless dermal nevus located on his face. Due to the nature of the boy's condition, the mother was visibly upset, and after completed full body examination, a small, slightly pigmented paper was noticed on the back of this boy. This is a closer look of the lesion. And we perform a dermoscopy, and we can see on a high magnification brownish background, but also we can see nice blue-gray dots and globules, and additionally some linear irregular vessels indicating the diagnosis of a possible basal cell carcinoma. Having in mind the child's age, palms and soles were also examined in order to find palmoplantar piece. Besides, I asked the mother for some odontogenic cyst or family history of basal cell carcinoma, and she denied any of these. We sent the patient for a surgical excision and pathohistological examination, which revealed surprisingly anastomosing strands of basaloid and squamous cells with connection to overlying epidermis, blind cells without antipia and mitosis, and low cellular or mixed with stroma. Immunohistochemical examination showed P40 strongly positive in basaloid cells. BCL2 stains peripheral basaloid cells, while in basal cell carcinoma we can find a diffuse staining pattern observed in all basaloid cells, and CD10 showed stains stroma around basaloid cells, indicating the diagnosis. All of this indicated the diagnosis of basaloid follicular hamartoma. Basaloid follicular hamartoma represents a rare benign adnexal tumor with a viable clinical presentation, often appearing as a cyst, plaque, or small skin-colored pimple, often clinically misdiagnosed. But also it can be misdiagnosed, as we can see, dermoscopically and even pathophysiologically. Originally, this follicular malformation was described by Brown and others in 1968, and it can be presented as a single lesion, or it can be presented with multiple lesions, which can be associated with more serious conditions such as myasthenia gravis and cystic fibrosis of the pancreas. This table summarizes differential diagnosis among basaloid follicular hamartoma, folliculocentric basaloid proliferation, trichoepithelioma, and especially infundibulocytic basal cell carcinoma. This is a recently published paper, actually, in the Journal of European Academy of Dermatology, published this year. It is a systemic review on dermoscopy of cutaneous adnexal tumor, and you can see that there are only 3 published papers until now on basaloid follicular hamartoma. So 3 cases of basaloid follicular hamartoma located in a head and neck region, and 1 on trunk. And also on dermoscopy, we can find in these published cases blue-gray brown globules, such in our case, some linear vessels, and in 1 case also comedolike openings were detected. This is one more interesting recently published paper of a basaloid follicular hamartoma accompanied with the basal cell carcinoma in 3 pediatric cases of basal cell nevus syndrome. And we can see here that in these cases, the basaloid follicular hamartoma dermoscopically was presented with the blue-gray globules, but with the absence of a vascular structure, while in basal cell carcinoma we can see again blue-gray dots and globules, but also arborizing vessels, indicating that in these cases of pediatric basal cell nevus syndrome, basaloid follicular hamartoma was dermoscopically presented without or in the absence of vascular structures. It is recently hypothesized that basaloid follicular hamartoma actually can be included as a characteristic findings in patients with Golden Gold syndrome. And finally, I would like to point out that although basaloid follicular hematoma is a rare entity, we should keep it in mind as a great pretender of basal cell carcinoma clinically, dermoscopically, and histopathologically. Thank you for attention.